Thank you, Siria. Thank you so much. And thank you everyone for joining in our session for the day. Today we'll be going through word suffering, which have a huge impact and meaning in everyone's life. And for walking us through the session, we have an eminent faculty, Dr. Deepak Varughese with us. It is indeed our pleasure to have him with us. Presently, he's serving as the senior resident in Department of Community Medicine with the Believers Church Medical College, Tiruvalla. He's a public health specialist with a special interest in primary care, family medicine, and palliative medicine. He has extensive experience in working with rural and tribal communities in both clinical and public health roles during his time doing MD at Christian Medical College at Vellore. So indeed, it is our pleasure to have you with us, Dr. Deepak Varughese, and we hope to have an eye-opener session with you. Over to you, sir.
Okay, so good afternoon, everybody. So I just share my screen. Visible?
Yes, sir, you're visible.
Yeah. So I know today's session is titled suffering, but a lot of that, of course, there are multiple facets of suffering and all of that, which we have obviously dealt with in other classes. We've looked at pain and we've looked at psychological sides and physical sides and all of those things with pain. And yeah, so today I think we'll be talking more in terms of health-related expenditure, because that in itself is a huge understanding that and trying to fix that, I think really helps one way. Because when you look at the whole concept of suffering, there's the symptom management and all of those things. And apart from that, there's also the economic side, and the that also contributes a lot to suffering, and this is all something that we all know. So we're going to look at that in a little more detail, because most of the rest of the things are covered at various stages. Are my slides moving? No, they're not, right? Yeah. Okay, so we're going to look first at two real situations that we've that somebody has described, and it's something that we do see. So I just want to really talk about that. So two examples, let's look at it. The first one that we see is so the first patient that we see is an elderly gentleman who came in with a life-threatening stomach ulcer. Basically a perforation or a tear in his stomach, which needed immediate surgery. And of course, the hospital was a fairly rural setup, but it was a fairly nice, a relatively low cost place. So they kind of, managed the costs, and they kind of brought that bill down to 10,000, which is actually quite a reasonable fair price for that kind of surgery that was done, right? And the second patient will look at another elderly gentleman who came in with acute inflammation of the pancreas, which was secondary chronic alcohol abuse. Basically, a lot of alcohol abuse leading to something that was not so immediately life-threatening, but they come in with a lot of serious pain, and that has to be relieved, using fluids and all of those things. But they needed to be admitted in the ward for a week, and the bill in this case came only up to rupees 1,200. Now, for many people, maybe here, maybe in other places, these two bills don't look like very big amounts, because they look like 10,000 rupees, 1,200 rupees. It looks fairly affordable, and that's the idea of having low cost care, right? But let's look at what happened. Okay, so for the first patient, who was the gentleman with the bill of 10,000 rupees, they paid it off without any complaining. But on further questioning, they revealed that he had taken a loan from a local money lender. I don't know what there are local terms for these money lenders. In Tamil, they call it vatti, and so there are these local loan sharks that give out loans for massive amounts of interest, and that is very high rates of interest. And so if that loan of 10,000, if he had taken today to pay that bill, that would eventually end up as 31,000 in the year, and which is almost a 214% increase in the principal. Okay, so of course, when the hospital found out that this was the situation, they intervened and they paid off the loan. But the question is, I mean, they paid off that amount and they kind of wrote off the bills and they tried to help a little bit. So here we have this hospital that's actually trying to do a lot of good. That's really brought down costs. But even in that case, you have problems like, these are very real problems. They're not scenarios that have been, purely, created out of, out of fiction. These are real scenarios. But these situations, what can we do as a healthcare system? Very little. But let's just look at what that can go about. For the second patient, which had a bill of 1,200, they found out that the family was offering to sell the 6-year-old daughter for an amount of rupees 400, which sounds very atrocious to us. Sitting in urban India, they may sound like, how is this even happening in India? But these are basically very much realities that are faced in many places in rural and tribal area. Now, the point that I'm pointing out and trying to tell you these stories is not that, I'm trying to kind of create some sort of a sentimental thing and kind of create some sort of a scare. That's not the situation, because that's not my intention at all, because it's just to kind of, put rural and tribal India in a little bit of context for urban India, because there's a huge gap, right? There are two basically situations where there is a growing, India, and there is another set, another group of people who don't really have this luxury. And actually, the large majority are people who do not have that affordability. So sometimes when we tend to think of things, I think it's important to have that broad picture so that we kind of have a broad distinction. So how do we approach this problem? Is this even a medical problem? First of all, it may not necessarily be a medical problem, right? So if you look at that problem statement, how do we solve this issue? One is better health financing, slightly out of our, health financing. We'll come to that. The other things are maybe affordable banking, stricter regulations of these loan chunks. These are all things that, we can't change the banking system. I don't know, maybe some of you may be bankers, but from the healthcare system point of view, we can't really fix, create microfinancing and all of that does not really come under the ambit of, traditional hospital-based system. Stricter regulations on interests, that's also not something that we can traditionally, we have a lot of say over. So how do we try to approach this problem? We just look at some of the things. I must give you fair warning that there's a fair bit of jargon coming. So, so please do keep that in mind. We'll get to why we are reaching here, because I think this understanding of this theory, even though it is a little bit of heavy topic, I think if we can grasp this, we can attempt to start solving some of the things. I'm not saying that there's a magic wand that we can sort out everything, but maybe if we try to get a grasp of some of these theoretical understandings, it can help us to kind of try to solve it. Especially many of you may be thinking of starting your own centers and things like that. So it may help to understand a little bit of the financial aspects. Yeah. So help financing really is concerned of how financial resources are generated, allocated, and utilized in the health system. Yeah. So where is because first of all, why bother about healthcare financing? You have a session on suffering, and I'm talking about healthcare finance. What is the connection? Why even bother? But obviously we are all practical. I mean, we're all people living in this place, and we know that to run any sort of a palliative care setup, there needs to come money from somewhere, right? That has to come from somewhere, and ultimately we have to have fairly self-sustainable solutions, because if you're because otherwise you can't really sustain operations, because palliative care is low cost. But even when you look at the fact of home care, delivering care at home, going from one house to the other, all of this costs money in terms of petrol, in terms of moving around, in terms of running a facility. So unless we have some idea about this, it becomes a lot of theory that's spoken in the air, whereas it's not being really grounded too much. So uh, of course, I really do understand that many people here may not be senior enough to make those calls. We may understand a lot of these things, but we're not really in a position to make anything. That's okay. And a lot of us may not, yeah, we may not be in a scope. I mean, as the scope of our current roles may not really allow us to do too much, but I still think it's important to get this, understand some of these things. Yeah. So again, why do we need money in healthcare? Salaries for healthcare workers, paying medicines from supplies, facility costs, all of those things, hiring a facility, paying rent for your building, all of those things, you need money, right? That's not too this thing. We look at the academic part, and then we look at some practical resources also, because it should not be too much. Okay. So whenever we talk about uh, when we talk about health, there's this thing that this bioethical principles that keep coming. I think I'm sure you've seen it in maybe some other presentation as well. You talk about autonomy, you talk about beneficence, non-beneficence, and justice. Uh, okay, I am not sure. Are people familiar with these terms? Yes, no. Okay, but I'll go about it one more time. Autonomy is what we keep talking about in what we keep talking about maybe in palliative care, where it is the patient has the autonomy to say what they want to do. Beneficence is that everything you try to do is for the good of the patient. Non-beneficence is everything that you're trying to do should not be harming any patient. And justice, right? Justice is actually the more complex of the lot, where you talk about maximum good for maximum people. Okay, so that may not, so some of the things that we talk about in terms of health financing, it may be like it may be like subsidized pricing and things like that, where it appears unfair on maybe one group of people, but the idea behind it is that you want to do maximum good for maximum people. So that's just the principle to keep in mind, right? Okay, so before going ahead, I want to define this word for catastrophic health expenditure. I think catastrophic health expenditure is any medical expenditures that can cause a threat towards the household's financial ability. Okay, typically it is described as if healthcare expenditure costs more than 10% of household income. That is typically referred to as catastrophic health expenditure, because it can cause problems for subsistence, because subsistence income is basically food, shelter, clothing, and certain household goods. There's another way to define it, which is 40% of non-subsistence income. That's okay. Let's not get into that. But simple understanding, WHO defines it as more than 10% of household income. This is something we see a lot in cancer. Not necessarily cancer. I know that we talk about why palliative care is more than cancer care, but cancer care specifically, there is a massive burden that comes in, because cancer is a very expensive disease, so to speak. So if it costs more than 10%, that is a problem. And I think this catastrophic health expenditure, at least in India, is the number one reason why people go from above poverty line to below poverty line. It pushes people into poverty, because a lot of people, we have our savings, we have, but one illness is what it takes to kind of wipe out people's savings. And that's kind of scary, because of course that's we'll talk about insurance and things like that, but that is something that is problematic. Okay, so when you talk about cost, okay, I'm not talking about what you pay for healthcare in the hospital. I'm talking about what it takes to run the healthcare system. When it comes about costs, there are direct costs and there are indirect costs. And direct costs include the costs of the instruments used, costs of services, costs of the costs of the pharmacy, the drugs that you buy, the consultation charges, procedure charges. All of these are direct costs that you actually pay. But apart from that, there are indirect medical costs, which is so direct costs are direct medical and indirect medical. So in indirect medical, you also need to have cost of transporting the patient, the ambulance charges. All of these things come to a decently big amount, especially in palliative care, because transporting patients in palliative care is a huge challenge. It's a big challenge. Either we have to transport the patient to us or we have to go to them. All of that is going to cost money. So those are all direct costs because you're actually paying that. But apart from this, there's also indirect costs, because a lot of times when patients are admitted in the hospital, you have caregivers who have had to take loss of pay. You may have people who, miss a promotion because of a certain mistake that ends up as loss of pay in the future. So all of these things are indirect costs that come to, that are problematic, right? Okay, so where does money come from, right? Money comes, so where does the money to run the health system? I'm not talking about where the money to, suppose you are running a healthcare system today, right? You want to set up an NGO or you want to set up a trust. Where is that money going to come from? It can come from governments, insurance companies, private companies. Somebody writes up a trust, somebody writes up a proposal to a funder and gets money. All of those things are there. But ultimately, we have to remember the money comes from the people, because this is how it works, right? Because people put in their money, they pay taxes. That's how the government makes money. If you're an insurance company, people pay premiums. That's how the insurance companies make money. If you've applied for a grant for an organization, that comes from profits of that organization. So that also comes, the money is coming from the people. If you are running a pure NGO, which you run only on donor money, there also money is coming from the people. So you have to remember that money comes from the people, and that comes with a sense of responsibility or managing that money well. It's not that I can apply to the government and that that's an unlimited source of fund. So it's just one. There is a responsibility to use the money that you have in a responsible manner and in a cost-effective manner. Okay, so where do you get this money from? I mean, to run the health system, it could come from taxes, it could come from insurance premiums, it could come from the money that the patients pay you or whatever, so, or other ways that, in palliative care, in resource mobilization, we have a lot of other things that we do in terms of, having auctions or having these runs, or all of those things generate money, right? So there is a large pile of money that is generated. And then, see, it's not that all the money that's generated for one person goes to that particular person, right? It doesn't always work like that. In generally, what happens is you have these financial resources coming from a lot of people that is pooled. And then there is this concept of risk pooling. Okay, risk pooling is something that a lot of insurance companies use, because that's why when I take a health insurance, it comes to a smaller premium. When somebody else takes a health premium, so not everybody who takes a premium will, pay. Not everybody who takes a policy will actually end up using that, right? So so that is a little bit about how this risk pooling works. So if you have a higher income, you're expected to pay a higher tax, or that doesn't mean you get a bigger share of the services, right? And so that's the idea of there is a certain pooling of money that comes in. So everybody pays taxes, only a few people get the benefits, but that's because of the risk pooling, right? So that's the one way that you can actually help more people, right? And purchasing is when you actually pay for the healthcare. You pay your salaries, you pay your, you do all of those things. Yeah. So how do you generally pay for services? Two things that we see in India mainly is fee for service. That is, I'm sorry if it's a lot of jargon, but I think it's just you can go through it later also so that you get a better thing. But fee for service is basically where you have a lot of it's this kind of model where you say you see 50 patients, I pay you this much, or it could be salaries. But fee for service is generally not looked upon as a good system, because especially in palliative care, because if you try to make this thing that tell your nursing staff that I want you to see 100 patients in a day and then only I'm going to pay you, then the focus comes on quantity and not quality. So that's not a very ideal way, because because especially in palliative care, sometimes home visit day you may see 3 patients or 4 patients. So from another point of view, they may be like, what is this? Why this thing. So if you pay people based on the number of patients they see, there is always a possibility of uh, compromising on quality. But that's not always the case. There are places where you would use it, but that's, I mean, especially if you're running, a small clinic somewhere, that, fee for service might be the most optimal thing. But by and large, you want to think also in terms of when you're running an organization, you want to be paying salaries. There are other things which I'm not going to get into right now, because that's another way of offering services. So largely, when you have an illness, how do you pay for it? One is directly you pay for it at the time of illness, and the second one is you pay for it earlier, right? So most of healthcare in India falls in the first bracket, where when you fall sick, you pay for it. But this is not ideal. It's not a very efficient way, because when you need to pay for us, when you need to pay for your illness, at that point you can't, maybe you may not be able to work. So that is a problematic thing. So direct payments at the time of illness is not ideal, but that's the 90%. I mean, most of what we see in India is direct payments, but other ways there is, in terms of insurance or medical savings accounts, not seen too much in India. Okay, so I'm just going to quickly go through all of this, because otherwise you'll get a okay. So yeah, so whenever you have a healthcare, so this is something that's practical. Uh, Whenever you're planning on how to use your money for people, and how to, your pooled money, how to sustain that organization, has to be feasible. Unless you have a financially sustainable model, it's not going to be practical on the long run. If you're going to always depend on external money coming in to run your organization, it becomes very problematic. So first question is it feasible? Are you trying to, so equity is something that's, a lot of times you have situations where you charge your private wards, or you charge insured patients a slightly higher sum, so that you can use that money to cross subsidize patients who cannot afford to pay. Is it fair on the people who pay more? Maybe not, but that's the most equitable distribution, because that way everybody gets care, because that's how the whole idea of equitability. Again, it should be efficient. Yeah. So the management you use, just because you have money, you still have to go for the most cost effective solution for that patient. You can't afford to, repeatedly do MRI for everything, or repeatedly do CT for everything. You have to but that is more in terms of from a provider point of view. Especially if you're doctors, think about what is the most cost effective solution. Do I really need to order that extra test? Maybe it may be justified. If it's justified, please do it. But if it's not justified, I mean, the biggest question that you have in terms of ordering a test is, if I order this test, does it change my outcome? I mean, does it change my management plan? So if the answer is yes, by all means order it. But if the answer is no, and if it's not going to change your management plan in any way, it may not be necessary, right? So think about how you can make from a healthcare provider point of view, how do you make it as cost effective as possible? Another thing is, maybe in terms of the medications you stock for your pharmacies. You can get a very expensive branded medications. There are companies such as low cost or CMSI, which actually give you generic medicines for a fraction of the cost. So, do you want to use generic medicines and kind of push down because a huge chunk of what you're paying for ultimately will be for medicines. So can you drive down costs in your pharmacies? Can you make that more cost effective? Because if you're buying the most expensive, the most branded things for every patient, maybe if it's patients that can afford it, by all means, yes. But do you need to get the most expensive brands or medicines? Can you get the same medicine for a slightly lower cost? So these kind of questions are things where you can solve. You can save some money here and there. So that is, technical efficiency. And sustainability obviously has to be a sustainable model. If it's not a sustainable model, it's going to fail at some point of time. You cannot run a system that is 100% dependent on external funding. It is going to have a problem at some stage. Yes, there are a couple of models for health financing. I'm not going to read it in a very detail, but just remember that most of healthcare financing in India is out of pocket, and out of pocket is the least preferred model of healthcare financing. Every time I fall sick, if I'm going to pay out of my pocket, that is a problem. Other than that, there are in the UK and the US and all that, you have single payer systems where, where government pays for everything through taxes. So the government pays for the health system in entirety from taxes that come in. And because of that, there's no competition, there's none of that. The government is the healthcare provider in the state. That obviously you cannot see in India. But the problem with that is, if you do that, you have a long waiting list because there is only the government system. The government system works in India, but it's not the only system that's there in India. India has a mixed method, but the beverage system or the single payer government system is where government pays for everything. In the sense, everybody pays health taxes, and from that taxes, everybody pays for this thing. But again, if there is a crisis or where there is a situation with a decrease in taxable income, very rare, that could be a problem. But this model actually sees healthcare as a human right, and the cost to the person at the time of illness is very low because they're already paying taxes for healthcare. And for this, obviously, but if you see if you see in the UK, 40% of the GDP is actually going into the healthcare system. In Sweden, 58% of GDP is, 11% of UK's GDP goes on healthcare. Sweden, it's 11%. Brazil is 8.4%. So it's all of these countries spend a massive proportion of their GDP on healthcare, so that when at the time of payment, the patients don't pay, you pay before in terms of taxes. This is not commonly in contrast. India spends, I think, 1.4% or something like that. It's less than 2% on healthcare. So that is a big problem that is there in India. Obviously, as normal common citizens, there's very little that you can do about it. But it's good to know that this is the system that's there, because very often when you learn health economics or when you read literature, you will see single payer window system and things like that. And then, so if you know this, it kind of helps you relate and helps you understand. The Bismarck model is something, it's more like, it's social health insurance. It's kind of like what your ESI scheme is in India, where the company or the employer pays for health insurance for all their employees. Yeah, so that is another system that's there. We see it in income, but another problem in India is that a lot of the people work outside the formal health system. The formal work system. So not everybody has an employer or something. Many people do. They're outside the formal system. They have a lot of this thing, and a large majority are outside the formal system. So will it work in India? It does work in terms of ESI and all of those schemes. Yeah. So private health insurance, again, that's what we commonly see in India, but a very small proportion of people actually have private health insurance. It's not very common. If you can afford it, please take it. That is very useful. But it's inequitable in the sense that not everybody can afford to pay those premiums. Not everybody is fit enough to pay those premiums. If you're above 60 and you try to take a health insurance premium, it's going to be very, 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 very expensive. So again, it's for profit and it's voluntary. But if it's that is one way where so even in private, it's the same principle that we set up risk pooling. So everybody pays premium, and finally they pay the chunk of that money goes to whoever needs it. So that's this. Community health insurance is something that a lot of people have tried at the community level, where everybody pays a certain amount, like a kitty or something like that, where everybody pays consistently. But the problem for that is, when somebody falls sick, you can't. They'll say that I have paid in this fund. Why am I not getting the benefit? So that risk is there. All of these systems also come with this idea of moral hazard, where people say that I have paid for insurance, so why should I not do this extra MRI? But that's not how it works, right? Because that is problematic. If everybody goes into that, that mentality that just because I have insurance, I can order more investigations, then it drives up costs. And that's why you have situations like in the US where healthcare becomes extremely expensive. So this is just a comparison chart where you look at out-of-pocket expenditure for India is around 62%, whereas if you look at place like South Africa, it's 7%, UK it's 10%. So India 62% is actually very, very problematic. So obviously if there are ways where you can get into move from out-of-pocket into other systems, that is the most ideal thing. Yeah, so that's that. So then we come to this concept of universal healthcare coverage, where all people should be able to access healthcare of sufficient quality without having to endure financial hardship. And that says that it doesn't mean that all people should get every service out there. It says that all people should have access to healthcare of sufficient quality without having hardship. Yeah, so that's the this is that pyramid that they show generally. So what you have is you have more and more services that are included under the UHC. You reduce cost. We aim by when we talk about universal health coverage, you'll see a lot of literature. Yeah, you'll see a lot of literature that says universal health coverage, universal health coverage. But basically what you mean is that all people should have access to healthcare of sufficient quality, some sort of healthcare of sufficient quality without causing them healthcare constraints. And so for this, what we aim to do is that one is we reduce cost sharing and health fees, which is this one, and we want to have all the you want to bring as many services as possible under health services, and then you want to extend the cover to as many people as possible. Yeah. Next slide, please. Next slide, please. Yeah. So for this, there are ways. Next slide. Next slide. So this is actually a nice little graph that you can see, where sometimes there are certain drugs, there are certain interventions, that are certain things that you have which are very high in cost, but are not. But the outcomes that they have is generally are not very. They're very high cost but very low in effect. So generally you want to move towards things that are relatively lower in cost but higher are more effective. So where you are placed on this X and Y coordinate is where is how efficient your health system will become. Yeah. So next, so it's not always that the most expensive treatment is the most efficient treatment. Yeah. So this is something that we have to understand, because a lot of times you want to go to the most premier institute or the most premier the most specialized thing, which may not be the case. You may be able to actually give more efficient care at a slightly lower price point. When it comes to medicines and when it comes to that, when you're choosing so for example, when you're choosing an antiemetic of choice, or when you're choosing the best drug for gastritis, one tablet of ranitidine costs much less compared to one tablet of esomeprazole. But generally when we write prescription, we tend to write the most expensive drug out there, because there is a theoretical benefit that the more expensive drug may be better, maybe the most efficient, maybe the best drug. But sometimes what is the best drug for that particular patient should take into account also what that patient can afford. And it's not very nice to say that, oh, that patient can only afford that much, so he got only that drug. But no, that's not the way it works. That patient can afford that much, so what is the best we can give him for this thing? I mean, that is something that is that's something that we have to look at. Can you go to the next slide, please? Okay, so one thing. So what I said a lot of Ramayana, I mean, a lot of this thing here, a lot of long stories, a lot of jargons, a lot of this thing. That was not meant to kind of create this thing that healthcare is so expensive. The point is, what do we do to actually try to bring this down? One thing what we talked about is being aware of the money lending practices and debt practices in your community. This is not something that people typically talk about, but be aware of that. If we know that we are somehow contributing to that, what can we do to avoid that, because you don't want people selling off their property and selling off everything for something that is not going to give them, that gives them maybe 2 weeks extra or 3 weeks extra of life expectancy. So finding that gap, finding that, it may not be the most, people may come and say, why, don't you have a responsibility to do everything? But no, be aware of what that patient, what it's costing that patient also. It's unfair to tell the patient that, oh, me spending on you is going to push me into debt. Nobody will, everybody will pay. They will take a loan, they will pay, they will sell off your property, but they will pay. But when you expect them to do that, the outcome that you get should also be of that, should be, if it's like a 50-50 chance or a 40-60 chance of it working, we have to weigh whether it's worth doing it or not. I mean, it's not enough to kind of have a sense of I mean, again, everybody has their own views on it, but it's something to think about. That's all I'm saying. So be responsible of users of money. Many a times you will get into situations, especially when you are dealing with donor money, where you can give everything to one patient. One patient may say the needs of that patient will never get over. He will want more and more and more and more and more. But how can I use this money efficiently so that I can give care to give sufficient care to maximum people? Somebody may, even after they have reached a point where they are okay, you might have started helping them when they were very much in problem, but they've kind of reached an okay situation right now. You have to also know where to pull that, take off the support. You can't always support. I mean, if you're getting money from a donor, how much are you going to be able to give one person at a point where you're not doing injustice to someone else? So maximum people you can help, give sufficient care to maximum number of people. This is generally a principle. There will be times where where it comes into question, but think about it. Just because 3 people, that's not the only 3 people who need that money or who need that service. Can you expand with that money that you're now spending on 3 people? Can you do something that's of slightly lesser distinct for 10 people? Something to think about. That's all. Okay. What is your own healthcare model in your organization and your district? Is it, even if it is donor money, is it something that's sustainable and feasible? Is it equitable in the sense that it's one thing to say that I will charge every patient equally, but it is also another thing to say that maybe I need to charge somebody who can afford it full price so that I can subsidize for somebody else. Maybe that may be something that you need to think about. And is it feasible at the end of the day? Are you cutting even? I'm not saying talking about creating some massive profit, but you need to at least cut even. You need to at least cover your costs with what you're charging patients, because it's easy to say that let it be. How can I charge for this thing? It's considered very big sin to charge in palliative care, but that's not the case. I mean, unless you're able to cut even tomorrow, your services may stop. And if your services stop, that's going to be a problem for a lot of other people. So think about it in those terms. Even if it's donor money, how sustainable is donor money in the long term? Can one rule, somebody's getting money from FCRA, overnight the FCRA rules changes, then what happens to your system? Your system completely collapse. So you have to be prepared for that. You can't just say that, this thing. I don't know if there are any doctors or physicians here, but be aware. The biggest thing that you can do is, yeah, so I don't think I'll be able to take my mask off. So, but am I not audible?
You're audible, sir.
Audible, sir.
Yeah, so be aware of how much you are charging patients. I mean, not charging patients, be aware on how efficiently you can charge patients. For example, if somebody comes for a CT with a head injury, which is not, but there's no loss of consciousness, there's no vomiting, there's nothing else. Do you really need to take that extra CT to rule out? because a lot of times we tend to become very defensive because there's a chance of lawsuits and all those things. But can we reduce the amount of investigations we're ordering? But I'm not saying do not order. If an investigation, please order it. But if it's not needed, can we avoid it? Can we go to a more cost efficient solution? uh, you have to be aware that every time you tell a patient come to my hospital and it's a bed bound patient, that's going to involve a huge financial cost. So can we not bring the patient here? Is there something that we can do where we can go to the patient? Because sometimes shifting the patient may be more expensive, but going to the patient may be costing you more. So what's the perfect balance between that? Another thing that is very powerful, especially in the Indian context, is there are a lot of schemes that are available on paper. Okay, but the question is, can you access those schemes? There is Ayushman Bharat. Ayushman Bharat is the flagship program for, we talked about UHC. Ayushman Bharat has been brought to help bring about UHC. So can you access government funds? Are there, can you go down? Next slide. So there are a lot of these, I just listed down a few schemes that are there. If you're in Maharashtra, there is something called the Mahatma Jyotiba Phule Jan Arogya Yojana. If you're in the health system, if you're in the ESI system, there is a CGHS scheme, there is an ESI scheme, there is the Ayushman Bharat scheme, there is migrant worker schemes. So I think as social, some of you may be social workers or not, I'm not very sure, but try to be aware of these schemes, try to be able, you need to know people with these schemes, I think someone's mic is on. Yeah. Yeah. So my point was that you have to be aware of these schemes. It's not optional to be aware of this scheme because people may be entitled to that money, but unless they know that they are entitled to that money, they won't apply for that. So you have to think about, especially working in palliative care, can you somehow streamline the process? Can you have someone from your organization uh, help them reach that, access those schemes? Can you do that for them? Is something that is very practical. We may not be able to change big things on the systems level, but what people are eligible for, if we are thorough in that, there may be ways that we can actually push them in and kind of help them get that they're eligible for. So that's something that is that can be a practical solution to these things. Yeah. Apart from that, there are private insurance policies and things. If your patients are people who can afford it, by all means help that. But it's also good to know a little bit about insurance policies, so that they can. Cancer in itself is sometimes in a lot of policies there is exclusions for cancer. So try to be aware of that before you take an insurance policy. So those are some of the things that we can do. Uh, in Kerala, I know that we have a fairly accessible government health system. Not everything in the government, there is a perception that government health system is bad, but can we leverage that? Is there certain things that you can send your patient to the government system for, where they can get those things for treatment? So be aware of what's available in the PHC nearby. Be aware of what's available in the tertiary centers nearby, because maybe this medicine that you are kind of struggling to get for your patient, it may be available for free in the PHC. So use that, use that for, be aware of what's available in the government system so that you can actually harness that and kind of reduce your costs, and kind of, help that patient out that way. So that awareness is something that's very key. Yeah. So that's the overview of how you can actually help reduce cost. I think I hope that was helpful if you're trying to set up your own systems. Yeah, so if there's any question, if there are questions of a discussion, let me just look at the chat. Using healthcare services or misbehaving health workers is not going to give better good health. I agree. We should not be abusing healthcare services. a lot of people in the healthcare system are working for the people. It's not that, I think a lot of times in palliative care, we get into this mentality that the rest of the health system is out to loot us. That's not the case. Many people in the health system are very good people. They want to help the patients. And I think if we get into this mindset of, the health system is evil and, trying to ruin us, that's not going to be helpful. If we want to talk about integrating palliative care into the healthcare system, we have to be, we have to appreciate what is good in the health system also. Then only we'll be able to integrate with them and try to bring that into the mainstream. If we're always at odds with the mainstream healthcare system, that's not going to help us in the long run. So that is there by abusing health. Anybody who's in a hospital, if they get abused, that's not acceptable. That's definitely not acceptable. Are there health insurance for low income groups? So private health insurance for low income groups is problematic, may not be this thing, but under Ayushman Bharat, it could be there. They may be eligible for certain things under Ayushman Bharat, under their. So Ayushman Bharat in the Kerala setting is called CAST. It's called Karuna Arogya Suraksha Paddhati. But for your state specific things, they may be eligible, especially if they are below the poverty line. There are a lot of schemes that are available. Like I said, if you're in Maharashtra, it would be the Mahatma Jyotiba Phule Jan Arogya Yojana. So you maybe want to look up about how they are eligible for that. That's that. It's equally important for the general public to be well informed and the costs involved. Yes. I mean, I think ultimately, see, there is a cost for the service, right? Even if you offer it for free, that cost for the patient, if they're aware of that, if they are, so if you charge them something that will help you cover that, that's great. There may be patients who are not affordable, who cannot afford to pay even that. So that's, you may choose to write that off. But I think knowing what each thing costs you as the health system, being aware of what that cost to you is kind of going to be helpful in kind of helping decide what you want, what you expect the patient to pay. Even if you're writing it off, you have to be aware that that was what it was. Because if you're not aware of that, finally, when you kind of get you're not going to be able to manage your finances well in the end of the day if you're not aware of that. Yeah, so I'm not sure if there were any other comments because I joined second after that. If there's anything else you want to ask, please feel free to discuss.
In the chat, there were nothing left, Dr. Deepak. You had covered all the queries. And so in case someone wants to put in their inputs.
A lot of it was jargon, but I felt it was necessary to get into that because sometimes if you're not, if you're not well versed with the jargon, it becomes you're not. The technical competency also should be there to kind of solve these problems. So then that's one step towards that. So.
Like necessary to understand the basic jargons, otherwise we'll be left behind when the world is running forward. It's Dr. Nupur
It's not a responsibility of the healthcare services to make everything well in every person's life. I completely agree. It's not the responsibility in the sense that we can't. It's not possible. Whether it's a responsibility or not is a different question. But it's not possible to kind of eradicate all of poverty, or it's not going to be a feasible aim. But if there are ways that we can, whatever we're aware of, at least if we know that there is a insurance policy or there is a CASP or something, there is a PHC there, what we can do, we should definitely try to do. I think when we start trying to do something, I think we'll be surprised at how much we can do. But I think unless you make that effort, it's this thing. But by no means am I trying to say that we can solve everything. When we try to solve these issues, if we try to solve 100 issues, we may be able to solve 5 or 10. And that itself is, something. Ayushman Bharat is not missed in this list. Actually, PMJ is Ayushman Bharat. So Ayushman Bharat has two components. One is PMJ and the other one is optimization of the sub-health, optimization of the conversion of the health centers into family health centers. So PMJ is Ayushman Bharat actually. It's not missing. In fact, Ayushman Bharat is what the government's scheme to, of course, the Ayushman Bharat in itself is a huge, is a different topic of discussion, whether it's feasible and all of that is a different discussion altogether. But what people are eligible under that, definitely try to connect them as much as possible, whatever they're eligible for.
Dr. Shaider wants to know which medical financial system is preferable, you think, UK or our subcontinent system?
What? I didn't get the question.
Which medical financial system is preferable, you think, UK or our subcontinent system?
So the UK, like I was saying, it has the like what is traditionally called the beverage model, where it's a single payer system, where there are no private players as such. Everything goes to the NHS. I mean, it's not that there are no private players, but everything is like everybody pays tax, and then there is the NHS, and you go via the NHS. So that is that has healthcare as a right, because everybody pays tax based on what they are earning, and then but healthcare is kind of viewed as a right. Our system is it is problematic in the sense that a huge chunk of it is out of pocket. Out of pocket is going to drive people to below poverty line. There is no doubt about it. So in that sense, I wouldn't say UK system is the best system around. There are different models that are there. UK also has its faults, but we generally want to try to advocate as much as possible for more spending on health from the budget. I mean, from the GDP. It's actually very pitiable that only 1.9, 1.8% of our GDP is spent on health, whereas other countries like the UK spend 15 to 20%. So that's not this thing. So because when we pay tax, it's not that government health system is only for poor people. Even all of us are eligible to actually go to a government hospital and actually get the care that we need. But I think until we reach a point where government health systems are of that standard, where people will come to them and all of that, that there will be a push and pull. But ideally, you want as much going to the government, because government provides you services for free. Yeah.
Or you would like to add, Dr. Shetu?
Every country, city, local medical system has to cater to local general public in their vicinity. Yes, I mean. Is there any particular NGO which is supporting palliative patients in different states like UP? Yes, there are a few. I'm not sure about UP in specific, but I think the Parliamentary Directory is there. I think Supriya can share that with you. I think it's there where they've actually mentioned every palliative care NGO. They've mentioned most palliative care NGOs. Supriya, can you share that Parliamentary Directory that is there?
Sure, I'll be sharing that in the chat in the while.
And I think that also has details of whether morphine is available or not. So that's definitely something that is useful. I'm not sure where is the directory. I know the directory is there somewhere here.
It's in the homepage only. I'm sharing the link right now.
You're sharing the link, no? Yeah, that's it. So I think the directory is a nice place because it even mentions, where is morphine available, where is morphine not available. It has the phone numbers. I think they did a lot of work in revamping the directory recently. So I think it's quite up to date also. So that's definitely a resource you can use. And that's there for the all India level also. So that's great. Yeah, so that's there. So
we have shared the link in the WhatsApp group as well. So
WhatsApp group, yeah. So UP specifically, also I'll share because so that's there. I think there is another Yeah, so my advice would be try to find out what are the schemes that patients are eligible for. There was a website, I think I'll send Sripriya the link later on today, where actually it's, I forget the name of the website, but they've actually gone and they let you search for by state which are the schemes available for healthcare. So I think that's a nice resource. I will share it in the after the session and try to, I don't know, the name escapes me. So I'll try to send that also so that you can actually use that to kind of figure out which is the health system. I mean, which is the schemes that your patient may be eligible for. It has eligibility for most schemes. So based on state wise, so that's nice. Anybody trying to set up their own own palliative care system in this group? Like, no.
I think they are in the learning process. So once we like reach towards the end of the sessions, maybe we will have new process.
Um, when you said that there is a role for culture, I absolutely agree that there is a role. I mean, you can't really take another place's model and put it in another place. So definitely there is a role for culture and local this thing. I mean, that's I'm addressing that question in the chat. So yeah, it has to cater to the local this thing. But as much as possible, if it can be as much single payer as possible, it's helpful because your payment is made before, so that it kind of gives people that room to manage that catastrophic health expense.
Any other inputs? Insights?
Now, maybe among people among you, maybe much better experts also. So I'm happy to take suggestions from that side also. It's not that I am the absolute authority in this thing. These are some things that may be helpful, but we can all help each other and try to figure out things together. So that's that.
So basically, all these our sessions are like the process of learning, unlearning, and relearning. We share what we have with us, and of course, we are very open to get in your suggestions and inputs, new knowledges. Dr. Looper was commenting every individual needs can be different. Very good. Does anyone want to say anything or Dr. Deepak, your solution?
That website is called Hapdarsha.
Okay.
I'll just share that also. It may be quite interesting for you to go through it. It actually lists down most of the schemes that are there in each place, and it helps you kind of. I'll just share that also in the link. So that's a nice website. You can actually go through that and kind of scroll to uh, your own state, and that will actually show you what are the uh, schemes available. So that will be kind of helpful for you, even if you're helping people out with that.
Many times it ends up that the people who are in real need, they are not having access to the exact or the correct data at the correct time. So they end up like, as Dr. Deepak told in the first case, the second case, that they end up lending money, borrowing money, and then getting clinched in the hands of the seller. So I believe this website will at least give you directions how to guide them so that they get the benefit. So I think maybe we can wind up today's session if no one else is having any other things to share. So, Dr. Deepak, we do know how busy a person you are. We understand your busy schedule, but then again, you found out time to share these things with us, those valuable things with us. And thank you so much from side of this cohort for having this session. It was nice hearing to your thoughts, and we hope to hear from you more. So, with that note, Sinia, it is over to you.
Thank you, Sri ma'am, and Deepak sir. Thank you. Thank you for such a wonderful informative class for us. And we are looking forward to have many classes with you again. And Sri Priya ma'am, thank you for being with us today. Thank you for facilitating. And Vaishnav, and without you, this class would be a